All right, I think we're good.
Looks great.
Eric, it's good. I had it on. It shared the wrong pane last time, so I think, are we good? We're good now. We're good this time.
Excellent, man. We see the perfect PowerPoint.
You guys could have just interrupted me. So formal. Anywho, thank you. What a great session again. Echo all the sentiments of just being able to come together and learn from everybody. Hopefully I can contribute a little bit here on massive cuff tears. And my task is to talk about fixing the massive tear or doing tendon transfers. And quite a Herculean task. I mean, I think we could have had a 3-day symposium just on this talk. But I'll attempt to get us through it.
Where's volume? Bottom right. Okay.
You guys okay? I don't know, someone's not muted there. Anyway, so what is a massive cuff tear? So in North America, Bob Cofield defined this as a 5-centimeter tear. The more traditional definition from Europe has been a 2 or more tendon involvement by Christian Gerber. And the clinical evaluation is critical, and you've heard a lot about this, and I'll touch briefly on it in that. We want to really look at the patient. So what you see here, this is true pseudoparesis. So this is the patient trying to raise their arm. On the left side, we're looking at scapular winging. Bottom left here is infraspinatus atrophy, and we're looking at scalloping there. And then fatty infiltration, as Dr. Schlegel and others here have pointed out. And this is pseudoparesis with what we call escape. So I wanted to just point out that lag signs are a tool that I use frequently. This Ralph Hurdle has pioneered, and looking at a lag sign of 7 degrees in an isolated supraspinatus tear, and as that goes up, this involves more of the superior and superior posterior rotator cuff with a high degree of specificity. So I found this really critical. And what this is pulling the patient's arm out, particularly into external rotation and an abduction external rotation for the hornblower sign. And if they can't hold that arm there, that's a positive lag sign, and we can measure the degree measurement that's happening there. Superior migration is really critical, and this is associated with large and massive tears, and a acromial-humeral distance of less than 7 millimeters may indeed portend a completely irreparable tear and poor healing. Touching on what you'll hear many of us talk about, the Goutelier staging here. This was a CT-based study, and what we're looking at really is either the stage 3s and 4s, where the fat is at least equal to the muscle or more than muscle. And the issue here, why that's important, is that several studies have shown that there's no functional improvement with even attempted repair with 3 or 4 Goutelier fatty changes on preoperative MRI, and is a strong predictor of postoperative re-tear and poor outcomes. So how do we know if a cuff is repairable? So there's a concept of a functionally irreparable tear with muscle atrophy, positive lag signs, static superior migration, fatty replacement on MRI. And does a massive cuff tear equal an irreparable tear? Maybe, maybe not. What about the tissue quality? And what about the tools in our toolbox, right? So these are all things that are really important. And there are a dozen options for massive cuff repair. We can just debride it. We can partially repair. We can transfer tendons, a patch, the SCR. We now have the biodegradable spacer. And then finally, the reverse arthroplasty. So I'm going to take a few minutes and digress into a little bit of a topic that I don't think is addressed elsewhere, but I think is really critical when we talk about this. So what about cost and cost effectiveness? And so the cost is variable. There's societal and systematic cost, there's hospital, but most importantly, what's the cost to our patient? And in the US, healthcare is 17% of our GDP, projected to be 20% by this year, $2.5 trillion in 2009. And expected to continue to go up. The direct cost of shoulder pain, $7 billion. The real issue here, though, is that we shouldn't be focused necessarily on cost, but taking a page out of my mentor's playbook here, JP Warner, is that what we need to talk about is value. And it's something that is not getting a lot of press, but really needs to. And I think our group here at CU and many others participating here are doing this. And I applaud the efforts, because this is the only way forward for us. And what value is the gain and benefit, be that survival, outcomes, patient satisfaction, divided by cost. And so this is based on 3 principles. and it shifts the importance away from the system and completely onto the patient. Care is organized around specific conditions, and that there has to be universal reporting of outcomes and results. And this is from Harvard Business School, Michael Porter and his colleagues. Rotator cuff over a 10-year period of time has shown a 141% increase in treatment, and shoulder arthroplasty a 250% increase. So shoulder care in regards to value basis is critical. Cordasco showed that outpatient cuff repair showed a 43% cost reduction and high satisfaction. Cuff repair versus observation and Vitale surgery was highly cost effective, on par with many other standard medical treatments. What about arthroscopic versus mini open? The scope increased the cost. That's largely, we think, implant related, and similar to our own Jamie Gennaro's study showing single row versus double row, that their analysis showed that double row was not cost effective for any tear size. I would, again, emphasize that this is not a value-based study. This is a cost-based study. So I'm not actually sure that that is indeed a negative outcome. The economic value of shoulder pathologies has been studied, and the bottom line here is that we need higher quality studies. At least 50% are poor at best, and we need to do a better job. What about the economic value, again, for society? Cost effective in all populations. The lifetime societal benefit of fixing a rotator cuff for $3.4 billion in about 250,000 cuff repairs per year. However, as has been pointed out, is maybe highly age dependent, and that's probably a relation to most likely tissue quality. And you can see here that as you march down this table, as the 10-year brackets of age increase, the net societal savings decrease. So just as Dr. Schlegel pointed out, the ones that we want to be fixing are the young, active, small tears, such that they don't progress to fall into this group if possible, and if we believe in this. Cost effectiveness, I don't want to steal anyone else's thunder, but this was shown here in the setting of a massive tear and pseudoparesis without osteoarthritis. They tested 3 conditions: cuff repair followed by revision, cuff repair followed by reverse or reverse, and showed that the most cost effective was attempted cuff repair followed potentially by reverse if they need it, though primary reverse did become cost effective when it exceeded arthroscopic cuff repair by only 0.04 quality adjusted life years. So now what? So there are so many new treatments, right? We have all these things, balloons and Regeniten patches and PRPs and SCRs and all this. So at what value and cost? So what if we have a massive irreparable cuff tear, but no DJD? So that's where I think we've really struggled. And this is where this concept of tendon transfers comes in. However, this is absolutely not a new concept. So latissimus dorsi for irreparable posterior superior cuff tears and the pectoralis have been worked on for decades now. And one of my mentors, JP Warner and Christian Gerber here, pictured in 88 when I was, I don't know, maybe I would have been in about 3rd grade. These guys were working out the biomechanics and the technique here of doing this with indications of mild to moderate weakness, an intact deltoid. They needed an intact subscap, no DJD or stiffness, and in a motivated patient. This is what it looks like. And so it's kind of a big deal. This is a big operation. So lateral position, typically we do maybe not this big of an exposure anymore, but a reasonably large exposure, exposing posteriorly the latissimus dorsi, remove it from the humeral head. This has been modified, and more mini-invasive and arthroscopic assisted techniques are available, but still kind of a big deal. And this is brought open over the head to reconstruct the posterior superior cuff. And our ideal candidate is someone young with an irreparable tear. Primary complaint is weakness. Gerber and others have shown an excellent 40 to 60 degree improvement in forward flexion with satisfactory outcome greater than 80. The bottom line here, though, is that this is really difficult. It's a big operation. You need a really skilled system in a really motivated patient to make this work. And I'd say most of us have honestly kind of removed this from our practice because of the difficulties surrounding that. So enter Bassem El-Hassan, our future Mass General chief, back to where he and I both did fellowship. And he's done an amazing body of work at the Mayo, looking at different tendon transfers and improvement in line of pull biomechanically. And so this is a brief slide from some of that work with the latissimus dorsi and the lower trapezius, which we're going to talk about. And so showing that the line of pull can be biomechanically greatly improved to replicate the posterior superior rotator cuff. This is what it looks like. So a small mini incision over the back of the shoulder. We add an interposition graft, be it a hamstring autograft, or most of us use an Achilles allograft through the posterior open incision, and then hook that up arthroscopically to the rotator cuff. And this has shown excellent results, though the literature is somewhat limited. Bossum published on 33 patients. He showed 97% improvement overall and 50-degree improvement in forward flexion. So really nice results. What about the subscapularis? So this was traditionally the pectoralis major, and I think we've all done this through our career. However, the outcomes have been variable and unfortunately generally poor in some situations. That can be improved if it's transferred subcoracoid, if they have an intact posterior superior cuff, and if the head is, of course, centered. This is what that looks like that Herbert Resch described, an open technique. This has been somewhat modified to split this based on the heads of the pectoralis. Though again, Dr. Elisan and his group have worked out a latissimus-based transfer, which improves the biomechanical pull, can be performed through a mini open harvest and then an arthroscopic assisted approach. However, unfortunately, limited literature so far regarding the outcomes. So what do we use when? And so my current personal algorithm is that if I have repairable tissue, they're indeed a first-time surgery, no DJD, and they're not pseudoparetic, so they can achieve at least 90 degrees of forward flexion, that patient in my hands gets a cuff repair. If this is the revision setting and they have functionally irreparable tissue, so that high-grade Goutallier-based tissue or tissue that we know we tried to repair in our own hands and didn't work with lag sign, particularly horn blowers without DJD, that's the patient that I think is indicated for tendon transfers. What about irreparable without lag signs? That's maybe going to be touched on in a later talk, but that's a patient that I would consider superior capsule or balloon based on patient demand. And then if they have those problems with DJD, that's a reverse arthroplasty. So remember, evidence, not eminence, should sway our decision-making. We need to get involved, follow our patients, honestly report our outcomes, and make changes based on those results. And I thank you very much for your time.